Okay, now hepatitis C virus is a curable disease. So in this module, we'll discuss about the diagnostic approach and the management and treatment protocol for hepatitis C virus. This is completely for educational purposes and for practicing physicians and budding doctors. That's Medicine Beyond Harrison's. If you're first time to this channel, do subscribe. Let's get started. So AASLD core philosophy is that to treat all hepatitis C virus patients, even chronic, acute, unless life expectancy is too short for a benefit. So the goal is to achieve sustained virological response that is almost equal to cure nowadays. With the advent of direct-acting antiviral drug, the cure is achieved. So always prefer a pan-genotypic regimens. Avoid interferon and ribavirin, which are drugs used in the past, whenever possible. So simplified treatment to enable universal access of hepatitis C virus drugs. So evolution of treatment. It was hepatitis C virus is a age-old drug, age-old infection. It was treated in the 1990s with interferon alpha monotherapy with no sustained virological remission and poor tolerance. Almost most patients succumb to decompensated liver disease or HCC. In the early 2000s, with regulated interferon and ribavirin, and there was a better treatment approach towards hepatitis C. And again, with the interferons and ribavirin, there is high incidence of anemia, depression. Again, hepatocellular carcinoma. All these were very common. In 2011 to 13, this is where the first generation direct-acting antiviral drugs came into the place. It is usually combined with interferon therapy. That time it was a very complex regimen with a lot of interactions, so hence again it was a failure. From the 2015 up to present, now with the advent of all oral direct-acting antiviral drugs, there is a high sustained virological remission with more than 95% and it has become a very safe treatment option. So HCV is now a curable disease. So management principles, assess the extent of liver disease, fibrosis or cirrhosis with a fibroscan, evaluate for extrahepatic manifestations, if present treat accordingly. Establish viremia, HCV RNA, quantitative or qualitative, or the core antigen. So ensure about the needle sharing and safe sex practices. Counsel about it. Psychosocial support should be given, and advice for alcohol abstinence because it's hepatitis infected liver is so sensitive for alcohol and can lead to rapid deterioration and decompensation. So these are the three direct acting antiviral drugs that you must remember. So only these drugs you must need to remember in the era of direct acting antiviral drugs and HCV treatment. So these are the preferred drugs, which is NS3 and 4A protease inhibitors. These are Glecaprevir, Oxaloprevir, Grasoprevir, and Simiprevir. NS5A inhibitors are ending with Asvir, A for A, Velpatasvir, Daclatasvir, Ledipasvir, and Elbasvir. Again, NS5B inhibitors are polymerase inhibitors. Again, these are Buvir, B for B, and these are Sofosbuvir, which is a nucleotide, and Dasabuvir is a non-nucleotide molecule. So only these drugs are now you need to remember in a treatment with hepatitis C virus. So multi-target blockade leads to an almost near zero resistant development for HCV. So current AASLD first line drugs in adults are Sofosbuvir and Velpatasvir. In India, it is available as Velplant. Almost cost around 18 to 20,000 rupees for a 28-day regimen. So this is given for a 12 weeks course, so which will require you 3 bottles. In these 3 bottles, you will get complete cure of hepatitis C virus. It covers almost all the genotype from genotype 1 to 6. It is a simple one pill daily regimen. Very simple. Okay, it costs around 55,000 to 60,000 for a 3-month course. So the next is Glecaprevir and Pibrentasvir. This is also available. It is for a duration of 8 weeks in non-cirrhotic patients and for 12 weeks in cirrhotic patients. Coverage, it covers again all the 1 to 6 genotypes. Simplified treatment algorithm. If the patient is having cirrhosis, compensated cirrhosis, then go for Glecaprevir and Pibrentasvir for 12 weeks, or suppose Velpatasvir for 12 weeks. If without cirrhosis, Decompensated treatment transfer for 8 weeks is enough, or you can go for Sofosbuvir Velpatasvir for 12 weeks. No genotype testing is required. It's for this simplified approach. In the past, with the usage of regulated interferon, ribavirin, all these genotype detection things were done in the past to give the appropriate drug of choice. Now, this covers all the 6 genotypes, so there's no point in checking for the genotype. So special situations in decompensated cirrhosis, don't use discriminase inhibitors such as Glecaprevir, Glecaprevir. There is risk of worsening hepatic failure. So in these cases, you can use Sofosbuvir, Velpatasvir with Veribavirin. This is the thing you must need to remember. In the case with decompensated cirrhosis, you must use Sofosbuvir, Velpatasvir with Veribavirin for 12 weeks. Or you can just go for Sofosbuvir, Velpatasvir. This will go for 24 weeks treatment. So ideally treat in transplant centers in case of decompensated cirrhosis. So in case of CKD, this Glecaprevir is the preferred drug of choice. Now it is said that Sofosbuvir are also allowed even in end-stage renal disease. This is the major guideline update now. But again, use cautiously because there is no much evidence in treatment of Sofosbuvir in renal failure. So HIV co-infection treat as mono-infection. Dual direct-acting antiviral do not reduce the efficacy of HIV drugs. So check for ARD and DAA interactions. HCV rate is comparable to HIV negative. So there is no issue with that. You can go ahead with treatment of HCV in case of HINA coexisting HIV infection. So HPV co-infection, this is the where you must remember. So both HCV and HPV can be seen in a patient. In such cases, eliminating HCV removes immune suppression on HPV. So always start a prophylactic nucleotide therapy, continue for 12 weeks post HCV therapy and monitor for HPV flare. So monitoring protocol, always do a CBC, LFT, INR, HCV, RNA, qualitative, HBV screening, HBsAg and anti-HBC total, pregnancy track and drug-drug interactions before starting the treatment. During the treatment at 4 weeks, always do a HCV, RNA quantitative to assess the compliance. At 12 weeks post-treatment, check for sustained viral remission. In cirrhotics, lifelong HCC surveillance is done with ultrasound and alpha-fetoprotein every 6 months. So, last and final option in the case of direct-acting antiviral failure, you can use Sofosbuvir Velpatasvir, Oxaliprevir. So, this also is a duration of 12 weeks therapy. Prior NS5A failure or relapse is the indication for this regimen. So, these are no longer recommended. This interferons in any form, ribavirin-based regimens, except in decompensated, where use in combination with Sofosbuvir Velpatasvir. So genotype restricted regimens for routine use is not recommended. And then again, resistant testing for most patients is not recommended. Liver biopsy for treatment decision is not recommended. So all these are not recommended at present. Just go with a direct acting antiviral drug combination. So summary, it is now the DAA era. So direct acting antiviral era. So HCV is now curable with more than 95% sustained viral remission. The pan-genotypic DAA are the standard treatment of choice at present. So at 8 to 12 weeks duration, you attain the virological remission. Those gone are those days where you gave a highly toxic interferon therapy with many side effects. Now it is not the case. So treat everyone, simplify access to HCV therapy, prevent cirrhosis and HCC. Then we'll try it along with WHO. We all put efforts to eliminate this virus by 2030. So hope you loved this video on watching hepatitis C treatment. So this is Medicine Beyond Harrison. If you're first time to this channel, do subscribe. Thank you for watching.